Okay, let's start then our study group. I'm sorry we're a little late. We had some functional problems here at the server, but everything's going plenty all right. This is Dr. Ken Weingardt. He is from Northwestern University, and welcome everyone to the study group. I'll pass the word to him since we're a little late. So thank you, I really thank you for joining us today, Dr. Ken.
It's my pleasure. Thank you. And good afternoon, everybody. Great to have this opportunity to talk to you all today. So we're having, of course, a little technical problems every time you have a talk about technology. This seems to happen. So bear with us as we go through here. So I'm going to be talking today about IntelliCare. It's a suite of apps, mobile apps for depression and anxiety that we have developed and tested here at Northwestern University. And I'm going to tell you a little bit about why we developed this suite of apps, what it is, how it works, and then I'll give you a little bit of our preliminary data about how effective it is at reducing depression and anxiety. Next slide, please, Kelvin. Great. So we'll start with what is IntelliCare. As I mentioned, it's a suite of Android mobile applications that are really designed to support adults who are coping with depression and anxiety. The apps are based on the principles of cognitive behavioral therapy as well as positive psychology. I think it's fair to say that we've drawn from a number of different evidence-based treatments to develop these applications. The apps can also be used alone. They're currently available on the Google Play Store for folks who have an Android device. You're welcome to go and download it and play with it at your leisure. And the point here is, though, that they can be used alone, so you can download them and use them. But they can also be used as part of a more intensive intervention where we provide some coaching support to the participant to help them have some accountability for completing the exercises in the apps, to provide them with some ongoing support, and also to help them figure out how to apply the tools that they're using in the context of their daily lives. Next slide, please, Kelvin. So how does this work? Well, we encourage patients to use the apps a few minutes every day, and the coach support can be provided by a secure messaging system. And coaches are trained to, as I think I mentioned this already, provide some warmth and support behind the application to help people with some technical problems that they may be experiencing, helping them to remove barriers that may be getting in the way of them using the applications in their daily life, and to encourage and reinforce attempts, as I said, to implement the skills in their daily lives. We'll probably cover this a little bit as we move through the presentation, but one thing to note about these applications is they're really designed to be used the way people typically use mobile apps. So rather than having a large curriculum of modules and lessons that people have to navigate, what we've tried to do is create apps that really fit with the way people use them, which is very brief but frequent interactions. And that we believe that that should really help with some of the attrition problems that are pretty characteristic of a lot of the other interventions in this space, where people just basically drop out. I think you'll read the literature and it seldom kind of comes to light, but many of these programs, if not most of them, suffer from serious problems with attrition. So many people drop out of the studies or drop out of the intervention before they can complete it. And we believe that one of the really key features of the coach support is that it keeps people engaged throughout the whole program. And this is really consistent with the findings of the literature that if we provide some live human support, somebody on the other end of even if it's a text messaging system, that can really be helpful in keeping people engaged with the program and working through some problems or whatever problems they may experience. Next slide, please. So why IntelliCare? Well, the idea is that because of the way the apps are designed, we want them to fit within the way people live and the way they use their phone. So, for example, rather than having people kind of go home and log into their laptop or desktop and devote, say, 45 minutes or an hour to using these applications, instead what we want is somebody who may be waiting at a bus stop, or they may be in line at the grocery store, and they may have a challenging thought, for example, or they may be feeling stressed out or anxious. We want them to have the tools that they can use at that moment, rather than having them study all about it and then having them try to remember, what they learned as part of that course. If we use IntelliCare as a frontline behavioral health treatment, we could really allow healthcare systems to broaden the care continuum and improve clinical integration and reserve more cost-intensive treatments for folks who need them. And this is actually something where we've been pursuing very recently, is trying to work with different healthcare systems here in the U.S., primarily here in the Midwest, but also down in our Southeast region, where we are working with primary care, integrated primary care settings, to implement the IntelliCare system in such a way that the care managers, or the patient care managers, have the ability to use this tool to stay engaged with patients who may otherwise kind of drop out of treatment, or once they're discharged from the hospital, they may experience some problems and come back in. And this is a way of helping to address that, and also to increase the capacity of the systems to treat more people with the same level of resources, right? Just to say, I don't think it's necessarily appropriate for everybody. I think some people need more intensive treatment as soon as they have contact with the healthcare system, and this isn't really designed to replace that in any way. It's designed to be more of an adjunct or a complement to the traditional services that people provide, at least as part of an intervention that was delivered in a primary care or a healthcare setting. So one of the statistics we're very proud of here is that 94% of patients who engage with the coached version of IntelliCare, that's the one where I have a coach sending secure messages, completed the 8-week program and demonstrated significant reductions in depressive symptoms. This is quite noteworthy because, as I mentioned, the typical finding in these studies is that 50% of the people will drop out. So we're really doing much better than, I think, the standard in the field. Next slide, Kellen. So what I'm going to talk about next are some of the tools for patients, and give you a little bit of an idea about what these tools are and how they operate. Next slide, please. So here's the mobile app suite, and I'll walk you through it very quickly. Again, you can find these apps on the Google Play Store today if you go looking for them, and they're available for free download on the Google Play Store. We do have the Apple iOS versions of the tools in development, and we hope we have 3 or 4 that are completed to date. So we hope to finish up the rest of them hopefully by September of this year. So let me talk you through it. The Thought Challenger is really a cognitive therapy derived intervention where people are given the opportunity to do some cognitive restructuring. So they get to catch the thought that they're having, check it against a list of distorted common cognitive distortions, and then change it with replace it with a more rational thought. Daily Feats is another application that actually it surprised us all because it's extremely simple, but it's also among the most popular of the apps. Basically, this is an app for folks who have a significant level of depression and are having a hard time getting started, kind of re-engaging with life. And so what it does is it sets a set of feats that the individual can accomplish each day, and as they go through accomplishing each of those tasks, they would check that off, and then if they accomplish all of them, they would get what we call a streak, and they would level up to another set of tasks that will help them, move forward in their recovery. And so some of the things in the first level are very basic steps, such as get out of bed, groom oneself, leave the home, things like that. And as they level up, they get more challenging types of tasks that they need to engage in. Purple Chill is an application that essentially is designed to support people's relaxation as a coping skill. So it provides some audio and visual exercises for relaxation, progressive muscle relaxation, deep breathing, that kind of thing. And I'll just mention one more. You're welcome to explore the rest of them. But My Mantra is actually a lovely application. Again, I think it works better than we had expected it to, where people are able to kind of come up with some inspirational quotes or words to themselves about things they need to remind themselves of each day. And then the app provides a way of accessing that information and even pushing notifications to the participants' phones so that they can remind themselves about what it is that's important to them or what it is that they're trying to accomplish. Next slide, please. So there's also a hub app. This is an app that is, we have the 12 IntelliCare apps that are similar to what I just described. And then there's a hub app that sits in the middle of this suite of apps. Its purpose is really to try to coordinate the patient's experience. So, for example, if any of the apps are sending notifications to the patient, all of those notifications are combined in the hub app so that people don't have to go searching through all their different apps to find the right one that's sending this notification. You also have easy access to all of the other applications available in the suite that you can download directly from the hub. What we find is that people who use the hub in a public deployment, meaning that we put the apps out on the Google Play Store and we don't necessarily provide any coaching or support for them. Hub users only 2% downloaded this hub, but the people who did download it actually use the apps much more than the people who did not use it. So some food for thought there. Next slide, please, Kelvin. So this is an example of the Thought Challenger application, just to give you a little better view of how it works. So I hope you can all see it. The Catch It screen starts out with asking people to come up with a thought that they may have recently experienced that was troubling or upsetting to them. The next screen asks people to check it, to stop and reflect on what they're thinking and see, is this really true? Is this true in all cases? But really kind of evaluate or interrogate the thought that they're having. The next screen over, the third one there, is helping people to figure out whether there are any distortions apparent in their thinking and to help them ultimately select which those are and then to change their thoughts. So they come up in the last screen with a more rational response to the situation that they encountered in the first screen. And so, as I said, people really seem to like this one. It also fits very well with the way cognitive therapists practice. At least here in the US, we have what we call a 5-column worksheet that helps lead people through each of these steps. And this kind of takes that and operationalizes it in a way that makes it easier for people to use. Next slide, Kevin. So, tools for coaches. So let me tell you a little bit about who the coaches are before we dive into how they do their work. The coaches in our research studies are research assistants. So these are typically bachelor's level students or recent graduates, I should say. This is a university graduate, but somebody who hasn't gone on to a postgraduate degree, such as a master's or a PhD. And we screen for people who have good warmth and support and ability to connect with participants, but not necessarily having all the skills that they need to provide the coaching, because that's something we can train them to do. This is really different than the way a lot of other systems have been set up, where it's basically a licensed therapist that provides this kind of support. So one of the advantages of using either research assistants or other staff in a clinical setting to provide this coaching is that we can expand the reach of the program pretty dramatically, right? Because each therapist, as I'm a clinician myself, and as you know, we only have so many hours in the day to engage with our patients. And this is one way of both expanding the number of people you could treat as a provider, because you don't have to spend as much time per patient, but also as a way of increasing the services that are available to the population, because you don't have a dependency on the number of providers that you have available. I think that's why some of the healthcare systems that we've been talking to are really excited about this tool, is because it allows them to increase their capacity for mental health services without having to hire additional mental health counselors or licensed independent providers, or practitioners is what we call them in the US. In the US, as I suspect in South America, we have an acute crisis in terms of the number of licensed clinicians we have, particularly in the rural areas of our country. So this is a problem that a lot of healthcare systems face and are trying to come up with technology solutions for. Next slide, please. Great. So what we're looking at here, the coaches, in our case the undergraduate research assistants, can access this dashboard, and I'll talk you through what it contains. If you look at the, let's start on the left-hand side, what you'll see is that there are alerts that are populated depending on what activities, tasks, or information the participant has due or has sent to sent to the coach that needs some response. As you scroll down on the left there, you can see a list of active participants. These are obviously we're using a research study, so we don't have people's names. We have user IDs. But what this tells us is what is the panel of patients who we're using IntelliCare to care for, and when was the last time that we contacted them? When were they enrolled, and when was the last time that we contacted them? If you look over at the middle panel there, the dots, each of those dots represent a usage of one of the apps. And as you scroll over it, you can see in that the dark box there, it says daily feeds. That's how you know which of the apps the participant engaged with. And so if you hover over the dots, you get some more information. This is just a screenshot, so it's obviously not working at this point, but you have a good sense of how it works. So this really allows the coach to see which apps and how often the participant is using them, and that's important information in giving them some support in terms of either getting more out of the apps that they're using or potentially trying out some different apps that may be more helpful for them. If you look in the middle of the screen here at the bottom, what you'll see is basically a text dialogue. There you go. Where the coach and the participant can send secure messages back and forth to one another. This is really one of the most engaging features, I would say, for many of our participants. Is it's not just an app that they're using, but there's somebody there who can answer their questions and help them figure out how to apply the skills that they're learning. And typically people are responsive to those. What we find here in the U.S., and it may be the case for you too, but as we get younger participants, their likelihood of answering the phone goes down. So we have many of our young people do not like to answer their phone. They're more likely to just want to engage with you via text or some other kind of application. So the secure messaging actually works pretty well because people can kind of fit it into the way that people can fit it into their life, at a time and place of their choosing. So it's asynchronous, meaning that they don't interact in real time. They just post messages, kind of like email or texting. And then as you go to the right-hand column here, you'll see some participant details. You'll see when they were enrolled. You'll see which apps that they were engaged with, and importantly, I think this is there it is in the second section there where you see assessments. What you'll see there is where we deliver the PHQ-4 on a regular basis as people go through the 8-week protocol. And that's a nice screen for, if you're not familiar with, I suspect you all are, but the patient health questionnaire. There is a 4-item version and a 9-item version. And both of them are pretty reliable and valid measures of depression. So we actually collect regular outcomes data as part of using the apps. And then for our study, we also collect more extensive assessments that happen outside of the tool. So we use a different survey platform, and our research assistant coaches then collect that information by telephone and set up a session to do that. Then there's a section at the bottom for notes, just so that if there's more than one coach kind of coordinating a patient's care, they have the ability to make notes as they go. Also, if there's a supervisor, if this is somebody who has a clinical supervision arrangement, the clinician, the supervisor can also log into the dashboard and see how the participant is doing and how the coach is doing. So if you go to the next slide, please. So I'll tell you a little bit about this study. We call this the public deployment study. That just means that it's a study of the apps that were downloaded by real users in the wild, as we say. So these are folks out in the community. They don't necessarily have a connection with a mental health provider, and they don't necessarily want traditional mental health services, right? But what we find out as we go, just looking at this slide here, of the people who went to the Google Play Store and downloaded these apps on their own without having a coach behind them, we got about 8,000 unique users between April 2015 and March 2016, and about 19,000 or 20,000 downloads. That number is actually, since I created these slides, that number has actually come up to almost 50,000 participants. Here we go. And the usage, 31 or 32% of people who downloaded one of the apps downloaded more than one. So that's really encouraging. It means that people must have had some sort of productive or useful engagement with the apps, because they then go ahead and try another one. As you can see, most people do only download one app, and that's really consistent with the way that app usage stats are for across different types of apps. Most people, and it may be consistent with your own experience, if you download an application and it doesn't do what it's supposed to right away, or you don't see that it's relevant or helpful to you, you're going to uninstall it, right? And that's the end. So that's one of the challenges of doing this work, is that people's standards are very high. The idea that you're going to come in there with an application that's more of a research product, and it may be a little rough, it may not have the same high quality user experience. It's difficult to get people to engage and to come back, and I think that's reflected in some of these numbers here. But still, we have a fair number of people who downloaded more than one. You can see 11% downloaded 2, 7.5% downloaded 3. So those are some numbers we would like to see improve, but I think they're still encouraging, because remember, there's no coach behind it. There's also no recruitment going on here, so we're not posting advertisements for people to engage with these apps. We have no money to do that. We have, as part of our research studies, we do advertise for our research participants, but remember, these are people who aren't participating in a study. They're just downloading an app and using it on their own. Next slide, please, Kelvin. Oh, there we go. Oh, very good. So let me tell you a little bit more about the public deployment use, now that we understand what that means. On the left-hand side of the screen, you can see some benchmarking data. So this is data that came out in 2014 in the Journal of Medical Internet Research. And essentially, if we're looking for substantive use or meaningful use of these applications, we would expect somebody to use it more than 1 or 2 times over the course of a week, a month, what have you. What we find in terms of benchmarking is that, or at least this author, Heliander, found, is that only 2.6% of people who downloaded a dieting app actually used it more than 10 times. So again, the majority of people download an app, they use it a few times, and then they uninstall it, and off they go. But if we compare the IntelliCare app usage to the diet app, that benchmark I just described, the percentage of participants who logged on to IntelliCare 10 or more times, it ranges from about 5% to about 36%. So we're actually getting significantly more engagement than the benchmark that has been set by folks who have studied dieting apps and other types of applications. And that's really encouraging for us, because remember, the tools are designed to be used for frequent, brief interactions. So the idea that somebody is using an app or a set of apps more than 10 times is really encouraging, because it means that people are coming back to it and finding some value in it. If you look at the table on the right-hand side, I'll just point out a few features here. The bold-faced numbers in that table reflect the highest rated or the most used applications. So if you look at the daily feeds line, that's one that I mentioned a little bit earlier. It's one that is extremely simple, and one that we didn't expect as psychologists were going to be very helpful, but lo and behold, people do find it acceptable and seem to use it a lot. So the number of launches for somebody who downloaded the Daily Feeds app is around 17, right? And there's a big standard deviation around that of about 40, so take that with a grain of salt. But it is quite a bit higher than the 2.6% that we see we're using as our benchmark. In addition, if you look at the number of days used the number of days that people have launched those apps, they could have launched an app more than once or not at all in a particular day. You see that about 25 people use the apps on an average of around 25 times in the course of a month. the number of days that they used it. And again, we have a very large standard deviation, so you'll have to take that in mind as you interpret the data. And then another example, I think I picked this one out as it's amongst one of the lowest used apps, is we got a number of launches of 3 and a number of mean days of use around 15. So not too bad, you know, considering that that's the lowest rated application. I should mention too that for in these tools for patients, where the idea isn't that we have it all figured out and we have designed the perfect set of applications so they're going to work for all people under all circumstances. Instead, what we're doing is we're actually taking each of them and asking whether these are apps that are performing to our expectations. Are they apps that people like? And are they apps that people download and use? And for those apps that people don't use very frequently or don't download or download and uninstall it, we're very willing to let go of those apps, to remove them from the suite of apps and add additional apps. That's actually one of the advantages of this architecture, is that we have a lot of flexibility in terms of the specific apps that we deploy. So if you or a member of this collaboration came to us and said, well, I'd like a new app that was based on to support couples therapy, or I would like a new app that was designed to support people who are recovering from a substance use disorder and help to wrestle with their cravings and manage those, we could certainly do that. We would need to design it in the same way that we've designed our other applications. But that's just a feature of the suite to keep in mind, is that we don't, it's not fully baked yet, if that metaphor resonates with you. But so there's an idea that we can continue to evolve this platform of apps, look at the performance of each, and potentially drop it if it's not doing well, and potentially promote the ones that are doing well a bit more. So that's it for that slide. If you would move forward, please, Kelvin. Great. So we recently completed a field trial here in Chicago. This is an uncontrolled field trial, so we didn't have a comparison condition that we were comparing the active intervention condition to. So again, kind of keep that in mind as we interpret these results. But so we've done a field trial. We had about around 100 participants who we were able to recruit into the field trial. The eligibility criteria were very relaxed, or very flexible, in that we only accepted participants who are 18 or older. And that's really just because of the IRB regulations and making sure that we don't potentially engage with minors who are under 18. The people had to experience some symptoms of depression or anxiety, but importantly, they did not have to meet the formal diagnostic criteria for depression or anxiety. So that's good. We're more inclusive in terms of the sample that we compiled for this study. If you're interested in finding out, this is a great website. If you're interested in finding out more about the IntelliCare suite of apps, it includes screenshots of each of the applications, as well as a description of kind of its clinical purpose and what it's about. And it also provides a link to an eligibility screener for our study. This one is currently closed, but we have a larger randomized clinical trial that is currently underway. And I can tell you a little bit about that. Actually, let me mention that now. So we have, this is a field trial. I'm going to share some results with you. We also have a larger randomized clinical trial that's underway. I think we're about 80% through recruitment there. And that's going to be a controlled trial where we look at the effects of the coach and versus not having that coach available in terms of people's ability to stick with the program and the types of outcomes that they hopefully will improve. Next slide, please, Kelvin. This is the field trial results, which we're very encouraged by. As you can see, this is the initial outcomes from an 8-week study. We have about 105 participants here. And what we're looking at in terms of the x-axis there is either a PHQ-9 rating or a GAD-7 rating. Both of those are, as you probably know, very widely used measures of depression and anxiety. And what you're seeing here is really remarkable in that it's a reduction of depression and anxiety symptoms by about half. And we very seldom see that, at least that size, that effect size, in these types of interventions. So we're very encouraged by that. If you go on to the next slide, Kelvin, and we're getting into the home stretch here, so we should have some time for questions. The field trial, what this shows is the references for the field trial and the public deployment papers that I referenced. What I could tell you here before I'll kind of close and open it up to questions is another feature that of the IntelliCare suite that I didn't prepare a slide for is what we call a recommender system. So the way this works is that if you look at the suite of mobile apps, participants aren't going to try them all at once. They're going to try one or two and see how that works for them. What we've been developing is an engine, as they call it, which sits in the middle of that suite of apps and kind of monitors how people are doing and then makes recommendations about which apps may be also helpful for them. So if you're familiar with Netflix or Amazon, where they have that ability to, I feel sometimes it's smarter than I am because it'll know ahead of time if I bought one item, I'm most likely going to be interested in a different one, or if I liked a particular film or a television show, that they can suggest ones that I'm more likely to enjoy. The way that works is that they're going to look at patterns amongst other people. So in this example, of IntelliCare, what would happen is that somebody, say they download the Thought Challenger application that I've been using as an example, and they have some clinically meaningful response to that application. So for example, they go in there, they open the page, they enter their thought, and they check that thought for distortions. That would count as a clinically meaningful event, right? And so what we do is we kind of count up those events. We find the apps that are most helpful for that individual. And then we basically look for other users who have found that app useful and also found a different one useful, right? So for example, it could be Purple Chill would be the second one, right? And so based on other people's preferences, we're able to make a recommendation about a specific app that's going to be most helpful for an individual participant. And that, I think, is a very a key feature of this system because it really uses some, I guess, artificial intelligence to help make some judgments about which tools are going to be most helpful for which people. And that's based not on our clinical judgment, but really on the basis of how other people have used the apps and which ones were effective for them. So anyway, it's a little bit complicated and a little bit above my abilities in terms of my mathematical and ability to describe algorithms. But I think it's a really interesting feature. So I'll just close by saying, there are a couple of things that make this suite of apps, I think, particularly attractive for users. One is that they're bite-sized, or they're modular, and there's the ability to use them just in time, just when you need them, and not having to go back to a computer or an app and navigate through different lessons to find the ones that are relevant to you. And the second is that recommender engine I described, where people are not only using their kind of intuitive judgment and preferences to decide which of the 12 apps is also going to be helpful for them, but we can give them some guidance based on other people's experience. And the randomized clinical trial that we currently have underway is actually comparing people who have received the coaching support versus people who do not receive that coaching. And then we're also, it's a factorial design, so we're also crossing that with participants who get recommendations through that system I just described, and participants who didn't get those recommendations. So it should be really exciting. We're going to be able to look at the relative contribution of the coaching and the recommender system to those encouraging results that I shared with you a little bit earlier. And getting back to my slides here, just on the left-hand panel there, that's a reference for the field trial that I described. And that's a really good place to start, I think, if you're interested in learning more about IntelliCare. Well, after you visit the website, that's the best way to get oriented. But if you're interested in learning a bit more, This paper actually got some attention here in the U.S. in the press because people see the utility of it. You know, depression, anxiety is such a big social problem, and we don't have the capacity to treat all the people who need help. So this is a great way of trying to fill that gap. And then the second paper there is just a reference to that public deployment paper where we look at the number of app launches and the number of the duration of those launches based on just the data from the Google Play Store. And I did mention that we are working on iOS or Apple versions of the apps that we hope to get out by the end of the fall of this year. So, next slide, Kelvin. Well, that really brings me to the end of my prepared slides here. You see my contact information there. I'm also a member of the Latin MH team and representing Northwestern. So if any of you are interested in learning more about this suite of tools or any of the research that I described, please do feel free to reach out to us, reach out to me through my email address there, or reach out to us through the website that has some wonderful resources that about IntelliCare, but also please visit our CBITS website where you can find more information about our various other projects, because we have quite a few of them going on now. So, at any rate, I finished a little early, but we do have some time for questions or comments if folks would like to offer any. Okay. Anyone? I'm not hearing any questions, so I'll look at my screen here, see if any are coming in. Am I writing? Calvin, are you seeing any questions come in on your side?
We're typing. I can see them typing here.
I know I talked fast, so I will wait patiently to hear what questions the group would like to bring. Calvin, am I supposed to see the questions in writing, or do you need to read those out to me? Because I'm not seeing them on my screen here.
Well, I don't know if you can see people talking here at the chat, but Bianca said, seems like a nice idea. I'll download it later. Thank you for the presentation.
Sure.
Maria Araújo said, thank you very much. And Andrea Tenorio is asking, in your opinion, what would be the barriers to use this kind of app?
Good question. Good question. I think, well, one of them is having enough money to be able to have a mobile phone that has the smartphone capabilities, right? So that, I think that could be a barrier for people, particularly in lesser developed countries, where they may have a feature phone, a flip phone, and not a smartphone. I think another barrier, to be honest, right now is that we only have it on the Android platform. We don't have it available for Apple iPhones yet, so I think that could be another barrier. I don't, some of the ones that have come up as we were designing the tool, one is really looking at health literacy. So I think that for users who may not have a high level of reading literacy, but also kind of health literacy, that could be a barrier to them using the tool successfully. Because the concepts that we're trying to communicate are not so simple, right? I mean, things like the thought challenger, my favorite example. Coming up with what is a distortion? That's a pretty long word for somebody who may not have a whole lot of education. So we did try our best to kind of boil those down, the strategies. and try to eliminate some of the psychological jargon from them so people can just access them. We hope that that has improved the user experience. Let's see, what other barriers have we experienced? There's challenges around recruitment, but I think that's true of any study. Some of the barriers could have to do with the lack of coaching support. So for participants who just download it on their own, they may not have the support that they need to get the most out of it. I'll tell you, one of the barriers that we identified ourselves and tried to fix is that when we started the applications, building the applications, there was a long instructions for each of the apps. I told them what it is, why we're using it, where the information came from, basically, setting up each of the applications. What we found out is that that was a big barrier to people using the applications. They don't want to read all the instructions, right? So as soon as we took that introductory content and we moved it from the front of the app, we made it where it was mandatory for people to go through, we moved that to the frequently asked questions or the help menu. That helped people a lot because they didn't have to read all this content and before they got into the good stuff. And the way it's set up now is there's really no required instructions at all. You just pick up the app and start using it. I think that's in contrast to some of the other interventions that are out there where they are very heavy on the didactics or the psychoeducation piece, telling people all about what they need to know and what's the theory of anxiety or the theory of depression and reasons why they're doing all these things. What we find is when we take out the information about the why, people are, for whatever reason, more willing to dive in and use the tools. So that was a barrier that I think we overcame pretty well.
All right. Other than that, Jacqueline Stintra said, thank you very much for your presentation. It's very enlightening.
Great.
Heloisa Claro from LariMH, Chest, are the apps protected with passwords or Google account? Can you start it in one device and change phones and keep from where you stopped?
Good questions. Good questions. So the one is the last one I heard was, can you use it across devices? And currently the answer is no. It's downloaded as a native application on your phone. There is a way that we can kind of, if somebody changes devices, we can actually help them to move it over so that they don't lose any data from that. In terms of the public deployment application, that is actually the only password protections there are for people's Google account. So if somebody has their password and they can log into their Google Play account, they could access the application. But I think not the information. The information resides on the participant's phone. We do have it set up now that we send some data with people's permission, of course, back to our servers, so we can look at not the content that they filled into the exercises, because that would be protected health information, but rather information about which apps have been downloaded and how often, right? Because that's more usage information than it is about people's private thoughts or private behavior that they certainly wouldn't want anybody to see. In the research study, of course, we obtain informed consent from our participants, and we make every effort to ensure that the information that they provide us stays secure and confidential. I've just been learning recently about the way that we do that, and it's something called a cryptographic hash. If we have any technological people on the phone here, that basically anonymizes people's data, so that even if we wanted to go back and recreate, who that individual was, we don't even have the ability to do that. And that's in the context of our research study. In the public deployment, we really rely on people's Google password protection, and then of course the protection on their own device.
Okay. Matthias said thank you, it was a great talk. And Julieta asked a question. Well, first she thanked you for finding the time to be with us, and then she asked, I wonder what are the risks from your experience of having no monitored interventions for people with mental health problems?
Very good question, and I think there could be some risks around that. In that, for example, if somebody typed in some information in one of these text boxes that said that they were going to inflict some harm on themselves or other people, if there's nobody monitoring that information, that could potentially be a risky, put the project at risk. Um, so the answer to that is that there is some risk involved. That's all disclosed up front in the terms and conditions in the informed consent for the people who are in the study, but in the terms and conditions of using the app for the public deployment users. And so we make it very clear to them that there's nobody monitoring this information and that it's not going to go anywhere. So if they're in a crisis, this isn't a tool for them to use. And I think that there may be some risk. We haven't really studied that at this point in terms of the public deployment users. But I think a lot of the products in this space have a similar approach. They just warn people at the front end that this is not a tool to be used for crisis, and that there's nobody, at least outside of the clinical trial, there's nobody who's monitoring this information, so that they shouldn't use it to communicate about emergencies and things like that.
Okay, she thanked you, and someone's typing. Oh, Susanna Shar from Letting MH, she asked, the coaches are mental health professionals?
Yeah, that's a good question, Susanna. No, they're not. They could be, but in our research trials, they're research assistants. So they're typically bachelor's level or university graduates who we provide some very specific training around using the coaching dashboard. And then there is a clinical supervisor who oversees the research assistants. And if there are any kind of questions about patient safety, or that the tool may be insufficient for treating a particular individual because of the severity of their problem, that the supervisor may intervene and offer assistance to that participant. Now that being said, there are other types of people who in the healthcare systems who would be, we think, a good match for these. In our healthcare system here at Northwestern Medicine, we have a staff who we call care managers, and I know that you have a similar positions in your healthcare systems and in South America, and those people are particularly well suited to be coaches, and they're usually not licensed mental health professionals, but we think they're in a good place because they're in communication with the patients, they know the patients, and they know what the issues are that the patients are working through, and what options may be available for patients who may need a higher level of care, right? So we can monitor that level of PHQ-9s. We can intervene if it looks like that is becoming, going into a higher range, a severe range. And then the care manager can make that referral to a mental health intake coordinator, et cetera. That all being said, I think there's nothing to prevent a licensed provider from using the tools and serving as a coach. I think that's a different model, but also one that's worth thinking about, because some of the research we've seen out of Europe suggests that if you use these types of tools as an adjunct to therapy, you can actually achieve similar levels of symptom reduction or similar effect sizes with less client contact hours. So the idea there is that if a licensed provider is serving as a coach, they should be able to increase the panel of patients that they care for, so that they can scale up their work, so that they can see more clients than one per hour. And particularly this seems like a good match for users who may have been in, say, an inpatient hospitalization and now going back to the community. This could be a nice way of them staying in touch with their counselor or provider. But the dashboard itself is really agnostic. It doesn't really matter who the person is on the other end of that. It's really how they use the tool. We do have I'll mention, we do have a manual for the coaching intervention as well that I'd be happy to share with y'all, to anybody that's interested, just so you can get a better idea of what the substance is of that intervention. And as I mentioned, it's not psychotherapy. It's really about supporting engagement, providing warmth and caring, and helping people understand and apply the skills they're being taught in the context of their daily life. So I think it could be an adjunct to therapy, but it's not therapy itself, if that makes sense.
She's typing. Um, she thanked you for the answer. And right now, I'd like to thank you very much, Dr. Ken. It was really enlightening. I'm really happy that you could be here with us, and despite all the problems that we got through today, but we made it. Thank you very much.
Hey, well, thank you so much for your help. This seems to be the way it often goes. So appreciate it. I'm glad we made it all work. And thank you for the opportunity. It's been a pleasure to talk to you all today.
Thank you very much. You really helped us out.
Have a great afternoon.
Good afternoon.